Welcome to the Pediatric Sedation and Anesthesia course. This is Dr. Gary Badger, Professor of Pediatric Dentistry at the University of Texas School of Dentistry in Houston. Today we're going to be discussing Module 13.
I receive no financial benefits that would create a conflict of interest or restrict my independent judgment with regard to the content of this presentation. At any time while viewing the video streaming course, you can take a break by simply pausing your computer. At the completion of this section, you will be asked to take a short exam in order to complete the requirements for streaming video courses. At the time, you will receive instructions regarding taking the exam. Section Overview. This section presents information to create an understanding of the continuum of sedation through which the dentist can make appropriate choices of pharmacologic agents that can be safely and effectively used for the various pediatric dental sedation procedures. This course is part of a 16-hour comprehensive program designed to meet the requirements of Texas State Board of Dental Examiners Rules 110.17. Sedation anesthesia of pediatric patients.
Today we're going to be talking about Module 13, Patient Recovery and Discharge. Images used in this presentation are taken from non-copyrighted sources in electronic media and attributed as possible. The de-identified images are provided as an educational resource to illustrate techniques and procedures for clarity. The participant should be able to recover the sedation patient to the level of pre-sedation consciousness. Discharge the patient to a caretaker after meeting the discharge criteria. Recovery protocols. Post-procedural care. After the completion of the procedure, keep recording vital signs until the patient responds appropriately to a voice or gentle stimulation. Sedation is stimulus dependent. Accordingly, when the procedure is completed, the child is likely to become more sedated than during the procedure, which can lead to hypoventilation and hypoxia. What happens when a patient becomes resedated? When the patient arrives in recovery, they are sleepy and becoming more awake. Once they are not stimulated, they become resedated. If that happens, what must be done? Resedation. When the patient arrives in recovery, they are sleepy and becoming more awake. Once they are not stimulated, they may become resedated. If that happens, what must be done? Well, the answer is a reassessment of the arousal of the patient must be done to see how sedated they remain. Perform the following. Determine what vital signs, respiratory rate, heart rate, PaO2, and blood pressure. Begin by stimulating the patient by calling the name, rubbing the hands, feet, or tactile stimulation. If no response, yet still showing normal vitals, administer oxygen, maintain an IV, or restart one. In this case, we can see starting the IV, if it's been removed from the sedation, involves finding an active vein where the insertion of the IV needle can be done. In most instances these days in the hospitals, we are placing IV sedations in veins in the hands. It used to be in the antecubital area, but now it's much more successful on the hands. So locating a vessel that will accept our IV needle is what we need to do. Selecting the right size needle to go into this at the right side patient is something that can be done in recovery by the recovery nurses and allows them to resedate or simply hydrate the patient, bringing them back to levels of normal consciousness. The third thing to do is check the respiratory rate. If the patient is not recovering, the heart rate, is that getting to a level that will be acceptable for us, and also the oxygen application. The IV is running if the patient is still within normal limits, recovering from the operating room. We may continue to monitor and continue to stimulate. If the patient begins to hyperventilate, apply oxygen and reposition. Check the heart rate, the saturation of oxygen. If no response, try painful stimulation such as pinching the shoulder blades or advancing the mandible with the jaw thrust maneuver. If no response again, check the breathing. If not breathing, perform rescue breathing, 1 breath every 3 seconds. This needs to be continuous until we see an improvement in the patient. If we have to perform the rescue breathing, ordinarily we can check the color of the patient and see if the lips are resuming normal color, but also if the fingernails, in looking at the beds of the fingernails, if they are turning somewhat purple, this means the patient is not getting adequate oxygen. And we have at our availability the oxygen provided by the recovery area, and we can just put that on a face mask that's attached to the patient's head. But checking breathing, if we have to breathe for the patient, we can do this rescue breathing. If we don't, we will continue to monitor and consider a tracheal intubation. Tracheal intubation is done the same as when it was done initially, and that is ensuring that the size is appropriate for the patient. At this point, with all the treatment done, it's possible to switch over from a nasal endotracheal intubation to an oral tracheal intubation. So it's something that can be changed at this point. If the patient recovers, continue to monitor. Monitor the vital signs, respiratory rate, the heart rate, make sure the IV is running, oxygen is applied to the face, and that adequate ventilation is occurring. If not, call the recovery nurse or EMS, and we'll consider reviving the patient with additional stimulation. Here's a situation when we have the patient in recovery. The patient has reported with teeth that need to be repaired, and here's the post-op sign. A recovery occurs when we see that the patient has regained consciousness, are conversing, sitting up and awake. It may be a little bit fussy. The parents will return to the patient and try to soothe the patient and see what's going on. But in addition to that, it's important to check the treatment site so that bleeding is under control. We can understand what needs to be placed in the discharge notes, that the patient is recovering to a point where we have sufficient amounts of post-operative instructions so that the parents understand what they have to do, but watch for oral bleeding. Discuss with the parent how to control any discomfort that may be going on. If so, we can prescribe analgesics such as ibuprofen or acetaminophen as adequate recovery medications to ensure that the patient is comfortable and also the pain is under control. Describing the diet that's expected. Typically we go from a very soft diet initially, progressing to a regular as the patient continues to improve. Some of the patient's favorite foods can be added to this. Jello, for example, was a nice soft food that gives them a little bit of nutrition, but also tastes good to the child. Popsicles that are available for children are available to give to the patient as they begin to awake and are able to do that. It's a very soothing thing to do, and the coldness of the popsicle will help to reduce any inflammation. As you can see from this patient, the right side, the gingival tissue is somewhat swollen, and this is the postoperative condition of this patient. It's really important that we try to provide as much nutrition and caring information so that the patient can go home with the parent. When they go home with the parent, it's important that we ensure that the dental assistant has been assigned to a postoperative care of the patient and discusses with the parent how to take the child home. We need to have a patient that's in recovery area, one that recovers easily, and there is a additional person assigned to take the patient home. The recovery area should have suction, pulse oximetry, and cardiac monitors. The pulse oximetry, of course, is to check the oxygen saturation, that the patient is sufficiently hydrated, and we can determine the oxygen saturation of the blood. Cardiac monitors are on to see if the patient has a continued observation of the blood pressure and the pulse, and we continue to monitor this as the patient recovers. Generally, when we're in the recovery area, we expect to see an increase in the heart rate of the patient as they become more awake and alert, and obviously they're coming into unfamiliar surroundings, so they're going to be a little bit more anxious than they would be when they went down. This enables evaluation of the two vital systems that are essential for recovery. The assistant should be instructed to record vitals every 10 minutes and more if needed to ensure adequate recovery, and that these vital signs are recorded on the sedation sheet of recovery. The parents can remain with the patient as they sleep off the effects of sedation in the required recovery area. Once the child begins to recover, we expect the parents to stand up to the side of the patient and offer encouraging words and reassurance that they're in good hands, and help the patient calm themselves down so that the heart rate will decrease and that the instructions that we give will be suitable for this patient to go home. They are instructed that the alarm for oxygen is set, and if they have any other concerns, to contact the responsible assistant, especially if the pulse oximeter alarm sounds. The pulse oximeter should show values between 94 and 98%, and to give us a reassurance that the oxygen saturation is adequate for the recovery of the child. Often the child awakes and plays when stimulated by the parent and can doze when not stimulated. Monitor closely to ensure that the heart rate and the pulse oximeter are achieving the effective results that we expected. Recovery protocol considerations. For non-hospital facilities, a protocol for ready access to ambulance service and immediate activation of the EMS system for life-threatening complications must be established and maintained. It should be understood that the availability of EMS service does not replace the practitioner's responsibility to provide initial rescue in managing life-threatening circumstances. In addition to that, the ambulance service takes some time to be able to get there, and it's important, should an emergency arise, that we have each of the staff in the office with a particular duty to perform. For example, if EMS comes to your building, and obviously they might not know the way in, have one of your staff persons assigned to stand out in the recovery area and wave to the EMS ambulance once it gets there so they'll know where to go. Also, having a location where an ambulance gurney can be brought into the operatory without disturbing the other patients. The other patients, in the meantime, have been moved to the reception area so they're out of the operatory area and do not have to be witness to the EMS team coming in to take care of what's going on. It might be frightening for young children to see the ambulance folks come in, and so it should be up to us to provide a staff member who is greeting the EMS folks, assisting them going down the hallway to the available operatory where the patient is residing and where the recovery team is working and getting replacing the patient's oxygen and the need for perhaps another IV. And it's the practitioner's responsibility to assign those tasks to the recovery staff. The contents of the emergency kit must allow the provision of continuous life support while the patient is being transported to a medical facility. And that means once they go into the hospital, perhaps the EMS folks have started an IV. They generally do not allow anyone to attend them in the ambulance, and family members need to go to the rescue hospital in their own vehicles or to another area within the medical facility. In facilities that have recovery areas, generally the patient is taken from the immediate recovery area to a secondary recovery area where additional pediatric advanced life support facilities are available. All equipment and drugs must be checked on a regular basis so that when these emergencies arise, they know we have current medications that will be able to take care of the child and be available in a current basis so that we can use them in any situation that may arise, that are maintained on a scheduled basis for replacement or additions that will help to keep the current medication and equipment current. Recovery is the availability of reintubating the patient, starting an IV, adding oxygen, and transferring information to the recovery team is essential for recovery. Letting the recovery team who is there know the patient's medical history, the history that's important in the recovery process, who is waiting outside for the patient to be there, reassuring the patients that the family members of the patient are out there and that they're reassuring that once recovery is complete, the patient will be able to depart. Hydrating the patient, the possibility of starting an IV and rendering intravenous liquids to rehydrate the patient, even after the operative procedure and the IV is removed. Sometimes it's necessary to reinsert an IV and continue to rehydrate the patient as possible. Ensuring the post-op area has stopped bleeding, the pain is under control, and the recommendation of ibuprofen, acetaminophen as pain control medications once they get home, and reassuring the patient to continue hydrating the patient as they get home when the patient is alert enough to take liquids by mouth. Discharge instructions are discussed, and it's clear what those instructions are and what the patient should do. It's often that the parents are quite anxious and need to have some reassurance, and so they may not remember all the discharge instructions. So it's common to have those instructions clearly written out, and the recovery team is familiar with what those instructions say and can verbalize those instructions and go down the list with the parent to ask if they have any questions. Transportation to home must be by a responsible adult. And that responsible adult hopefully is the third person who comes with the parent, because the parent must be there to drive home, or the responsible adult can drive and the parents of the child can be there and understand what their post-op instructions are, have the opportunity to ask any questions that might help them transition from being in the hospital setting or being in the day surgery area, going back home, and know what to feed and how to care for the child appropriately so the recovery is very smooth and there's little discomfort associated with this. Pulse oximetry is important for recovery. We know that as the patients wake up, they have been getting some oxygen within the operating room, and it's important that we look at pulse oximetry to make sure that the ventilation is continuing to reoccur as needed, and that on room air they're back to a recovery where the 21% of oxygen in the room is sufficient to keep them awake and to help them start being awake, as well as getting the blood pressure. In this case, we're looking at 120/80, which is normal, and the 37.1 to 37.4 is the capnography reading that tells us that the patient's falling within a normal range. The 93 temperature that the patient has is not of concern. Recovery protocol. In general, discharge criteria should include the following. The child's vital signs should be within 15% or 20% of the baseline readings, either above or below. The child should be ambulatory as appropriate for his or her age. Often as that starts to happen, if you have toys in the recovery area, the child will want to walk over to where the toys are. They have received IV sedation to be able to help them, or some intramuscular sedation. Oftentimes when we use intramuscular sedation, they may still have some soreness in the muscle where the injection of the drugs was made. The child should be able to ingest and retain oral fluids. If they are in the daycare surgery section, they are continuing to get IV sedation until the patient is ready to be discharged and to go home, or until the time as they reach over and try to pull out this insertion of that IV. Then we need to be able to allow them to take that off. A dedicated and properly equipped recovery area is recommended. That usually is an area that's quiet and has recovery personnel to be there to monitor the patients, attaching the monitors like the pulse oximeter, the blood pressure cuff, and sometimes capnography to ensure that the patient is recovering based upon those objective criteria. The time and condition of the child at discharge from the treatment area or the facility shall be documented, which includes the child's level of consciousness and oxygen saturation in room air have returned to a state that is safe for discharge by recognized criteria. A return of vital signs to pre-sedation levels is the goal of recovery facilities. Oxygen saturation on room air, pulse rate, blood pressure, alertness and ability to remain awake for 20 minutes without stimulation. Often, when parents are watching the recovery of the patient, they will want to hold the child in their arms and it provides stimulation. When that happens, you want to ensure that the parents know that the child's head should not be touching, or the chin should not be touching the chest. As they cradle them in their arms, they want the head back in a sniffing position so that the airway remains in as optimal position as possible. Careful observation, including imbalance, verbal conversation, and recognition as to the time, place, and name is essential. Knowing where they are, what their name is, how they're recovering, and those are questions that can be elicited by recovery room personnel. Pulse oximetry and capnograph are essential post-operative instruments to measure the oxygen saturation of the hemoglobin, and the delivery of the oxygen to the patient and ventilation is occurring appropriately. This capnograph has a 36% millimeters of mercury that are occurring on this patient, and that is the capnograph reading. A 98 is usually the heart rate of the patient and can continue to monitor how the patient is doing and allow us to make sure a safe recovery is occurring. Recovery, patients receiving supplemental oxygen before the procedure should have a similar oxygen need after the surgery. Patients receiving supplemental oxygen before the procedure is an idea of where we should start with our oxygen levels. Patients with multi-organ medical condition, long half-lives of rescue drugs administered, or pose a risk of resedation may require a longer period of observation in a less intense area before discharge from the medical dental supervision. A separate recovery area away from the operating location provides for that quiet recovery. Observation in a suitably equipped recovery area, which must have a functioning suction apparatus as well as capacity to deliver greater than 90% oxygen in positive pressure ventilation with a bag valve mask with adequate oxygen capacity, as well as age and size appropriate rescue equipment and devices. The patient's vital signs should be recorded and at specific intervals, for example every 10 minutes, no longer than 10 minutes according to Texas State Board of Dental Examiner rules. This is what recovery looks like, and it's basically a child who is very sleepy, recovering from the sedation drugs that were given, and really wants to be in a recovery position. This is considered the recovery position on the patient's side. You can see that the arm is being held up there close to the assistant's arm, ensure that the recovery is complete before the IV is removed. And as soon as this patient begins to wake and is stimulated, they may start to open up their eyes, calling their name gently, rubbing their back or their chest, making sure that they are completely soothed by the recovery personnel and they're recovering in great condition. If the patient is not fully alert, oxygen saturation and heart rate monitoring shall be used continuously until appropriate discharge criteria are met. And what are we looking for? We're looking for a heart rate that is at the level or slightly higher than it was when the patient came in. And so because we have placed in our sedation record what the oxygen saturation is, we would expect that patient to have oxygen saturation levels and heart rates similar to what it was when the patient had baseline vitals taken prior to the sedation. So looking for that to occur is the aim and the goal that we're shooting for before releasing that patient to go back home. Patients that may have received reversal agents such as flumazenil or naloxone will require a longer period of observation because the duration of the drugs administered for a rescue may exceed the duration of the antagonist and resulting in resedation. Special patient recovery considerations are, does this patient take any special medications? Are they cognitively developed to a condition where they will know where they are, or they won't start to panic once they start to wake up if they don't see a familiar face? So it's up to us in recovery to ensure that we have parents available once the child starts to wake up. The child will be looking for the parent and will be soothed by the parent's voice and be able to recover. Particularly for special patients, it's important to the timing of the parent attending and being back with the patient is coincided with the time that they're waking up, so that information will be projected by the parent when they wake up. Yes, it's all right to be awake. You're in good hands. I'm here. Don't worry. Everything's under control. Remember, we're at the hospital and you had your teeth worked on. All these are soothing and calming voices that are there to make the patient realize that they're in good hands and the patient's parents are there to take care of them. Patient recovery considerations have been that the patient has been sedated, require close observation once they've been sent to the recovery area, where the following items should be attended. Aroused, the patient should become aware of the surroundings and recognize familiar faces and voices such as a parent or caretaker. The fluid should be offered as the patient has been NPO for the sedation procedure and may be hungry. Things like popsicles are good to have because the icy popsicle will feel good on the gums of the teeth and reduce any swelling that might occur post-operatively. Also, the administration of ibuprofen and acetaminophen will be used, and we know that those medications don't take effect immediately, so if the patient's going to be there for a period of time, sometimes it's good to have the staff deliver some anti-inflammatory elements, and generally the hospital or sedation OR staff provides some analgesia prior to that patient leaving the operatory. Recovery considerations. Nourishment or water may be offered that is easy to consume when the patient is fully awake and alert. If it appears as though recovery is going to be a longer period of time, we may wish to have some popsicles or jello available for them to take as they begin to become more awake. Oftentimes, it's nice to have some ice chips for them to suck on, to have a straw in which they can drink, and have some water along with those ice chips, and just to watch them carefully so that they are not sedated to the point where they may swallow an ice chip. Ambulation, the patient may have to urinate and be able to walk to the bathroom. Often that's necessary after they've had IV liquids given to them. Lactated ringers is often the liquid of choice. It is good to know that the kidneys are functional. The patient should respond to verbal and physical stimulation without return to sleeping and should remain awake for 20 minutes, unstimulated. This is a good thing to warn the parents of when they are sitting there with the child wondering when they're going to recover, or more likely when they can take the patients home. So if we indicate to them, they're often the ones who want to stimulate the child by saying their name or rubbing their hands or holding their hands or rubbing their forehead, some ways to stimulate the patient, and then we've instructed them they should remain awake for 20 minutes unstimulated before they're allowed to go home. If a patient has slipped into deep sedation from the intended moderate sedation, a longer period of recovery will be needed. Again, we're looking at our monitors to let us know how the patient is doing. Oxygen saturation will be an issue that we'll want to be seeing. If we still have the capnography attached to the patient, that'll also be watched. The IV to make sure that that's continuously running and providing some nutrition for the patient to go on, and that there's additional amounts of IV sedation that may be offered to the patient while they're still recovering. They've slipped into IV sedation, but moreover, it's a way for us to ensure that we have a vein open for the addition of perhaps reversal agents or the addition of hydration fluids. Those will be important if the patient has slipped into deep sedation. So we'll be watching the patient carefully that they are going to be aroused from purposeful, verbal, or painful stimulation that allows us to ensure that the patient is waking up properly. And if we've had to administer some reversal agents, that we may have to add some additional reversal agents to that patient if we are worried about the consciousness of the patient. The ability to independently maintain ventilatory function may be impaired, and if it appears as though the patient becomes resedated, it may be necessary to use our IV and to administer some drugs that will help to reverse the situation, but also provide them some IV fluids. And it is possible that with careful observation, sometimes we may have to apply some rescue breathing, which is 1 breath every 3 seconds if the patient fails to breathe for themselves. And if that's the case, we may wish to add a reversal agent to make sure spontaneous ventilation occurs, but watching that to ensure that if it's inadequate, that we are ready there to supply some help with that particular function. Cardiovascular function is usually maintained, therefore we don't have to worry about proper heartbeat, but we have the defibrillator available in case the patient slips back into sedation and we have the heart rate stop. So we have that defibrillator ready. EMS may be called to support this if we don't have a recovery nurse, but with all of these features available to us in the recovery area, we should be comfortable that the patient will get back to average levels of arousal to be able to be discharged according to the sedation. A state of deep sedation may be accompanied by partial or complete loss of protective airway reflexes. If we see that, the patient may pass from a state of deep sedation to a state of general anesthesia. This is not what we expect, but if it's something that occurs when the patient has been under sedation and goes to general anesthesia, it's important to be ready to add devices which will monitor the deep sedation and going into the level 4 sedation to have the adjuncts necessary to continue to monitor the patient and ensure that ventilation is being done, positive pressure may be required. It may be necessary to use some oral endotracheal intubation that may occur, the availability of oxygen to pre-ventilate the patient to a higher level of inflation with oxygen prior to the attempt at reintroducing the endotracheal tubes to be able to breathe for the patient. So determining exactly where the patient is and what is needed is a really important aspect of recovery, and it's important that we have those situations in place so that if something should happen, we are ready to change the physiology of the patient through the pharmacodynamic means and reverse the depression of the neuromuscular function and bring the patient back to a level of arousal. That one person must be responsible to observe the patient's vital signs so that we can continue to follow recovery if deep sedation was an issue with us in the operating room. Deep sedation recovery of a child that's been deeply sedated will require a trained individual that can administer oxygen as needed. If, for example, a child has difficulty ventilating, then that assigned person will continue to provide ventilatory support with rescue breathing until the child can ventilate independently. and continuing to keep our eyes on the pulse oximeter to watch the pulse rate go on, and we'll continue to provide ventilation for the patient if necessary, and that ensures that the recovery should have a functioning O2 and suctioning delivery system for clearing the airway to avoid laryngospasm and the difficulties associated with that, and ventilation can take place appropriately. The child, as recovery continues, should be easily aroused by physical stimulation, such as rubbing the chest or arm. As I mentioned, the eyes will be open to observe the source of stimulation. If the child seems to recover to sleep or return to sleep or be unable to be aroused, then the application of a painful stimulation can be used, such as the jaw thrust at the angle of the mandible. As the patient becomes more awake, the patient may become fussy and cry. Then the parent can calm the child down, make sure that they are coming into the recovery area, encourage wakefulness and stimulation while still having the support of trained personnel monitoring recovery. If the child can breathe oxygen, then that would be helpful to encourage, as well as offering assistance in oxygenation. Parents that are present must be sure that recovery is progressing, and it is very normal to return to full consciousness slowly. If an IV has been used, it is prudent to continue with it until the patient is fully awake, and then they try to remove it. That's the time to remove it from the patient. Taking vitals such as blood pressure, respiratory rate, heart rate are a good way to assess recovery, as well as pulse oximetry and capnography. We know that patients who go home in the car tend to want to go to sleep and go back to sleep, and that's something that we must prepare the patient for, that they may not eat a full meal when they go home, even though they have been NPO, but they would rather sleep than do that. And it's up to the patient's parents when they get home to ensure that they are watched carefully and monitored, and if they're sleeping and breathing and their head is elevated, everything should be just fine with that patient, and ensure that they know we will be calling them later to see how the patient's recovery, and let them know individually that if they have any particular concerns, they will be available to call us and let us advise them over the phone whether to come back to the hospital or to continue stimulating them, providing hydration, and ensuring that they're breathing properly. Airway patency and adequacy of ventilation to either administer drugs or to direct their administration. The person must have PALS certification training in pediatric advanced life support and skilled to rescue a child with apnea, laryngospasm, or of airway obstruction. Required skills include the ability to open the airway, suction secretions, provide continuous positive airway pressure, insert supraglottic oral airways, nasal trumpet, or a laryngeal mask airway should intubation be necessary, and to perform successful bag valve mask ventilation, tracheal intubation, and cardiopulmonary resuscitation. These required skills enable the clinicians to be on hand should the patient slip to a level of sedation that has been unprepared for but anticipated. An ECG monitor and defibrillator for use with pediatric patients should be readily available. Vascular access should be placed. If it's been removed or the patient has awoken and taken it out, it's important to have it ready should we need it to be able to reinsert a vascular access to be able to deliver medications that may help to reverse the deep sedation that the patient has undergone. A recorder should be documenting all medications used and communication of drugs used, clearly stated, the duration of time, and the time of administration. Discharge criteria is a matter of looking at the vital signs and airway stability. Is there no nausea, no fever, patients oriented to surroundings, who they are, where they are, what day it is, recognizing the guardian, knowing what their name is, they can walk, they can talk, and support their head, they're well hydrated. Post-treatment instructions are in writing and verbal. If we have discussed this with the parent, they at least have this to take at home. Oftentimes the parent are very stressed and they forget everything after the first responses that we've given to them. So verbal and written instructions are really important. The guardian is available so that when the patient becomes awake and alert, they can go home. I remember when my practice had patients that we had in recovery, there were sometimes parents would have to leave for one reason or another, and here we were at the end of our day wanting the patient to go home, but the parents was not there. And since we learned that can happen, we require that the guardian, the caretaker, is there the entire time while the patient is recovering. If the patient is in the operating room, we insist that we have one of the parents available there for the entire time. Occasionally, under treatments in the hospital, we've had parents, even though we've told them to remain there, have gone away and are unavailable by their telephone, and so we've had to continue to keep the patients in recovery until the parent shows up. Obviously, it's a little upsetting to know that the parents are not concerned enough about their children to remain there to be available for immediate discharge, but that's kind of what we do to ensure that the patients are there. Documentation of recovery is critical, and situations such as I just described are written down carefully. The anticipated time that recovery was there, the time that the parent was not available, and that nursing personnel were available to take care of the recovery of the child. A numerical scoring system is generally used to assess discharge criteria, and it provides an objective measure of readiness for discharge. Examples include the Aldrich Discharge Criteria, which was developed in 1995, and the Patient Assist Discharge Summary Scores are discharge criteria also developed in 1995. Different locations have different discharge criteria. What happens after discharge has been documented by studies such as this study by Dr. Rittrick in 2013. They evaluated 46 children after sedation that used meperidine and hydroxyzine versus midazolam alone after 8 and 24 hours. In both groups, 50% of the children slept in the car on the way home. 3 children in the MH group, the meperidine and hydroxyzine group, vomited in the car. Not a good sight, I'm sure. A larger proportion of the children in the meperidine hydroxyzine group experienced prolonged sleep when they went home. Oftentimes, children, when they go home and get back to familiar surroundings, are very comfortable and relaxed, and they may even sleep through the night with good monitoring from the parents to regain their energy back to be fully aroused the next morning. More children in the meperidine, demerol, hydroxyzine group exhibited irritability in the first 8 hours. This is not uncommon, particularly in the midazolam group, which is this group I talked about, not meperidine and hydroxyzine, but the midazolam group. The MD group is the midazolam group, and midazolam has been typically described as having an irritable recovery period, and this instrument that discovered how they were doing is verification of this reporting that the nurses have been able to do. Also in the midazolam group, what we have noticed in our experience is that children, when they recover and they start to leave the operatory, we tell them to be careful of the speed bumps because children tend to stumble in their immediate post-operative period when they've had midazolam. So as we said, more children in the midazolam group exhibited irritability in the first 8 hours. This is something to watch for and to warn the parents about. There was no statistical difference between the two groups with respect to the incidence of pain, fever, vomiting, sleeping in the car, and difficulty in waking up after they have been discharged from the clinic. So midazolam versus meperidine and hydroxyzine had virtually the same responses to the sedation agents that were used. Most events occurred in the first 8 hours, but some exhibited effects 24 hours later. It's not clear what those effects were after the first 8 hours, but we know that effects were, and it's likely to be very sleepy, sort of lethargic, not being fully coordinated. Those are the types of things that we have heard from our patients. A study by Dr. Dosani in 2014 evaluating 50 children with combinations of sedation regimens for midazolam, meperidine, and hydroxyzine. The parents recorded on a timesheet every 2 hours from discharge until bedtime incidences of behavior, alertness, activity level, motor imbalance, emesis, and soft tissue trauma. A questionnaire asked about transportation, supervision, and return to normal activity. 66% of children slept in the car. Remember that Dr. Rittrick's study showed that 50% slept in the car of both conditions, but here 66% of the children slept in the car. Of those, 30% were supervised by only the driver. Can you imagine driving home and not being able to monitor where your child slept? If they slept in a car seat, where many of them do, it's quite likely that their chin could drop to their chest and be an obstruction for their breathing. And 12% were difficult to awaken. Imagine the alarm of the parents when they take them home. They really need to have another person evaluating what's going on and insist upon that when the patients come to your office and want to be sedated. Insist that they have a third person who can drive home or monitor the patient when they're going home with recovery. Agitation was observed in 22%, regardless of midazolam or meperidine and hydroxyzine. Restlessness in 10%, withdrawn behavior in 16%, and soft tissue trauma in 18%. The soft tissue trauma is not surprising. If the soft tissue trauma is confined to the gingival tissue, the gum tissue which surrounds the tooth, then it could be possible that discharge showed that if crowns were placed on the teeth, we might expect to have some soft tissue trauma. If the soft tissue trauma, however, was from perhaps biting on their lips or biting their tongue or some other level, it would be good to know what they observed in the soft tissue trauma to see what we could do to help mitigate those circumstances when the patient going home from recovery. So it's important to look at these studies, see what they tell us, learn from those studies, and be able to adjust our protocols to intercept these problems before they develop in the children. For example, the soft tissue trauma. What could we have done to prevent the soft tissue trauma if it was indeed postoperatively involved? Maybe they stumbled and hit their lips or something. We don't know exactly what that is. 18% is nearly 1 in 5 of those patients who exhibited that kind of trauma, and it's nice to know what those are. Motor imbalances was significantly associated with midazolam, the same as the Rittrick study, that the motor imbalances, as I mentioned, the midazolam stumble, watching for the speed bumps in the carpet, as was restlessness. 82% slept between discharge and the bedtime, with 16% sleeping for greater than 4 hours. These are typical things that we have learned from these discharge studies, and it's important for us to return to normal activity was greater than 4 hours in 36%. So nearly a third of these return to normal activity levels that it was greater than 4 hours that we expected and was inversely correlated with age. And that means that the older the patients, the quicker the return to recovery area and normal activities. Discharge, the use of an objective rating document to evaluate the recovery condition prior to discharge, verifies the return of physiologic parameters and avoids post-operative mishaps on the way home. For example, the patients we just talked about who were sleeping on the way home, those that were unmonitored for the time period that they were going in the car and only had the driver monitoring what was going, and also at home. Are the patients recovering well? We need to know if post-operative mishaps on the way and at home are intervened and that we have provided post-operative instructions to avoid and understand what's going on with each of these patients. The Alderates and the PADS scoring system provides a numerical score to record prior to discharge evaluating physiologic parameters. That means if we are comfortable with the patient discharge parameters and the patient score is high, they're much more ready to go home than if their scores are low. And that's what we're looking for. Here's an example of the Aldrich discharge criteria done in 1995. For oxygenation, the SpO2, which is the saturated pressure of oxygen determined by our pulse oximeters, if they're 92% on room air, they're no longer getting oxygen supplement, but 92% they were on room air, they were greater than 92%, then this tells us that the patient's recovering better on room air, and they receive a 2. If they're greater than 90% on oxygen, then they get a 1. If they're less than 90% on oxygen, then the score is 0. So oxygenation is very important to us, that we see ventilation is occur, oxygen is being utilized, and they have a higher score when they get back to breathing room air if they are greater than 92% with the pulse oximeter. Respiration, the patient's breathing deeply, coughs freely, and the coughing is something that's not associated with recovery, or it's not associated with something like asthma, but it's associated with the sedation drugs that were given. The patient breathes deeply, and the secretions that were building up while they were asleep under general anesthesia, these secretions are being swallowed as appropriate, and that means that the patient's recovering very well and the swallow reflex is intact. They get a 2. If the patient is dyspneic, which means they're dizzy, shallow or limited breathing, then they will get a 1. And if the patients are occasionally stopping for a few seconds before they take another breath, then they're still sedated to a degree and they need to be 0. So as the patient recovers, when they get to that level of 2, then they can get back home. Circulation where the blood pressure is plus or minus 20 millimeters of mercury of the normal value, the baseline value. If they're within 20 millimeters of mercury of that normal value, then they get 2. Let's say that the patient's blood pressure was 120 over 80, and so if the blood pressure is 100 less the 20%, or 140, if they fall in either if they're 100 or 140, then the patient can go home. The blood pressure is plus or minus 20 to 50 millimeters of mercury of normal, the normal value, then it'll receive a 1. We don't want to be 50 millimeters of mercury below the systolic blood pressure of the patient, because if we started out 100, that means they're going to be 50, and that's not something that we want to see. Or if we started at 120, that's 70, that's not what we want to see in terms of systolic blood pressure, and the patient gets a 1. So if that's what the case is, they get a low value reading in their recovery protocol. Blood pressure is more than plus or minus 50 millimeters of normal, and it's more than 50 millimeters of mercury above is not so good, but below is certainly not very good, then they get a 0. Consciousness, are they fully awake? If so, they get a 2. If they're arousable on calling, a 1. They're not responsive, they get a 0. Activity level, they moves all extremities, they're playing in the recovery area, or moves 2 extremities, maybe just moving their arms and legs or moves their fingers, then they just get a 1. If they don't do any movement at all, then they're held at the 0 level. Pre-sedation levels of consciousness, the baseline are very important as postoperative goal. One can compare where the patient's levels are and use the Aldrich score for approaching the 20% level of preoperative value as a guide. An accurate sedation record can permit one to assess the ability to sedate children and return them to street-ready levels expeditiously. If you have that record, you can look back at your recovery protocol and see, was it an appropriate recovery time frame? Perhaps the sedation level, the doses that were given to the patient did not allow them. If the child is normal and average and they don't have any medical conditions and the patient's recovery was long, situation, then we want the patients to return to street-ready levels expeditiously. And if our sedation record indicates that for the typical patients, let's say take 10 patients from your sedation record and look back at those sedation records and see that we gave them 50 milligrams of Demerol, it might show us that if we were at 40 milligrams of Demerol, they were adequately sedated and they were able to be recovered and discharged at a quicker level. That's what we would want to do that more expeditiously so the patients could go home. Here is the post-anesthetic discharge scoring system, and vital signs within 20% of preoperative values is a 2, then the patient gets a 2. If it's 20 to 40% of preoperative, it's 1. If it's 0 and greater than 40% preoperative value, then they get a 0. Activity and mental status, again, is similar to the Aldrich score. They get a 2 if they're oriented as to person, place, and time, and they have a steady gait, they get a 2. If they're oriented person, place, or time, or they have a steady gait, one or the other, if they can get up and walk and they're steady gait, then they get a 1, or if they're oriented to who they are, where they are, and what their name is. And then also if they get neither of those two things, they get a 0. So you can see that's going to hold up the discharge. If they have pain, nausea, and or vomiting, if it's minimal, you get a 2. If it's moderate, then you give the patient a 1. If it's moderate and they've had some nausea and vomiting, you may wish to provide them some anti-nausea medication. Zofran, for example, 4 milligrams, would be something that you could give to the child so that they stop having the nausea feeling. Also, Phenergan is a drug that can be used to help with post-op nausea. And 0 if they require treatment, such as giving them the medication Zofran or Phenergan to control their post-op nausea. Surgical bleeding, if it's minimal, you get a 2. If it's moderate, there's still bleeding going on, your patient stimulated or their tongue is going up to the area of surgery, and there's still bleeding, they get a 1. And if it's a 0, then it's severe bleeding, and bleeding is welling up into the mouth, they're requiring suction, then they get a 0. Intake and output of fluids. The patient has had a PO fluids and voided. That's great news. We know the kidneys are working and the patient's able to take drinks, sodas, or not sodas, but water by mouth. Then the patient has recovered sufficiently to have a 2. If they've had PO fluids or voided, one or the other. Oftentimes patients, when they come back from recovery, have got a full bladder because of the IV sedation that's been going on. And if they void and you check their diaper and everything seems to point to the fact that they've voided appropriately. And if they have, then they get a 1. If neither of those things has happened, they can't take fluids by mouth, or they haven't voided, they get neither. This delays recovery. For total PAD score is 10. The score is greater than 9. They're considered fit for discharge. The clinical discharge criteria have stable vital signs. The patient is alert and oriented. The patient is free of nausea and vomiting. They are steady of gait, and the patient has no significant bleeding. I have found in my practice that visiting with the patient postoperatively is a really important aspect. First of all, it shows that you care about the patient, but also you have the chance to discuss postoperative instructions with them, that you verbally told them what was on your written sheet, and the personal touch of being there with them, watching the patient recovery, and being successful at having delivered a very excellent sedation. The patient awakens very quickly, and you see that they can walk around. They've been given their prize for being at the office, and the parents it's been discussed, and reassuring them that we have a telephone number, you can call me, reach me at any time. This is something that reassures the parent that the first priority that you have is the welfare of the patient. So that at the time of discharge criteria, once your nurse advises you to go back and the discharge criteria have been met, this is important time to spend with the parents, and it's worthwhile to be able to do this so that they know how much you care about their child. Transport is sort of the final thing that we want. First of all, we want the patient fully recovered, and the parent or the caretaker is prepared for the discharge. The parent has someone who will come with them, who will observe the child or drive the car and let the mother observe. The observer is instructed to ensure that the child's head does not drop down to the chest and that mild stimulation is needed to keep the child awake. Mild stimulation in the form of perhaps holding their hand, rubbing their forearm, putting your hand on their shoulder, reassuring them verbally that everything is okay. If the recovery involves added sleep when the child reaches home, that's okay, because you can put their head on a pillow to elevate it. Ensure that you have pillows around them so they're not going to slip down and have their chin touch their chest. Instruct them to sleep with their head elevated on a pillow. Also telling them to put a towel on the pillow, that they don't mind getting soiled, because oftentimes if you've extracted teeth, there's some post-op bleeding that tends to weep out. And I say weep because you don't want a lot of bleeding. If it's strongly pushing blood out there, you want to make sure that they have put a towel over the linen on their bed so they don't have that problem to deal with. And tell them that if they get more than just a few drops of blood on the towel, that's important for them to call you so you can help them with the postoperative instructions. The postoperative instructions ensure that the parent has a contact number for the dental office. In my case, I had them have my personal telephone number so that I could answer any urgent calls, and I advised them that urgent calls would be pain, infection, swelling that would go on. If they had any of those three things, they need to feel free to give us a call. If they had nausea and vomiting and it was a hospital patient, we asked them to contact the emergency room or take their child over there, and that the emergency room was prepared to handle nausea and vomiting and could prescribe some medication for them. When we typically had our patients leave the operatory, we had postoperatively in our postoperative orders supplied the patient with an anti-nausea medication such as Phenergan or Zofran to be able to ensure that no post-op nausea was occurring. But you cannot account for what the patient's parents are going to do when they get him home. They might think, oh, you poor thing, you've been through this difficult procedure, and I'm just going to give you something to eat. And in spite of the postoperative instructions for starting off very slowly with a progressive diet from something soft that goes down easily, or soup, or not to eat anything hard, they will ignore those warnings, and they indeed will trigger some vomiting, and then they'll get an office later on to check on the patient's welfare. We might find out when we call them that they threw up once or twice. If it's more than twice, we want them to go to the emergency room where they can handle post-op nausea. They're accustomed to doing that because there's many patients in the hospital who might report there. We happen to be dental, but there are other patients that are there. And so if there is a postoperative complication such as that or continuous bleeding, we need to know about that. And that's something that the ER has been trained to give us a call and let us know exactly what's happening with our patients. And it should be your practice then to go in immediately to the hospital. If there's somebody that's worried and they brought their child to the ER after hospitalization or sedation, then you must go and find out what's going on. If you don't do that, that does not show the caring that's necessary to maintain a pediatric practice. So please consider that when you're getting these calls from the emergency room. And that also you have trained the emergency room to provide indications to you when your patients come there. That those patients will say, this is my doctor, he's Dr. Badger, and I want you to give him a call, I'm worried about this or that. Ensure that when they do that, that you've instructed on them to look for pain, infection, and swelling. If they've seen any of those things, to give you a call saying, hi, this is so-and-so, I'm the attending nurse at the ER, and this patient needs to see you. They've called, they've asked for you. It's important that you are the one that goes in to see them. They really appreciate that, and it shows that you are caring about what's going on with that patient. And if there's any concerns about that, let's say that they have some post-op bleeding from around a tooth, or maybe a tooth has loosened when they have fallen on their way home, it's a reason for you to go in there. If the parent is concerned, you need to be concerned. And that's something that you do to build a practice and make sure that those patients keep coming back to you. Instructions about immediate diet progressing to regular are written and provided to the parent in their language of choice. You need to have a signature on this because we want to ensure that there is some documentation in there that you have discussed with the parent the immediate diet that's going on, and your initials want to be close by too, because it says that you're the one that talked to them about the postoperative instructions, and it shows when they go home they forget that you've talked to them, and if there's some untoward event that occurs, the first thing they say is, my doctor didn't come and talk to me after the procedure, and you've got a record of it showing where they've initialed their chart. So that's an important aspect to remember to kind of keep your practice sane. Now, questions that we have: a 5-year-old patient, for example, is entering recovery after the dental treatment under sedation. The patient appears a little dusky around the lips and the fingernail beds. So what are you thinking when the first thing happens? It's a little dusky around the lips and the fingernail beds. There could be 2 reasons for this to happen, and the capnograph displays the image below. What is the likely cause of the reading? So you have the choice of equipment malfunction, pulse oximetry is low, the sedation is causing this reading, the patient has asthma. So think about that for a minute. We'll see, what is the answer to this? So equipment malfunction, pulse oximetry is low. If that's the case, or the sedation is causing this reading, does it mean that they're still sedated, but they're entering recovery, so they could be a little bit sleepy? And finally, the patient has asthma. What does a capnography reading look like when you see them? Okay, time's up. And here's the answer to the question. Equipment malfunction, no, we've got the capnograph that shows that the patient's millimeters of mercury is rising above 45, and it's not the capnograph, it's generally the shark fin shape of this tells me that the pulse oximetry is low. That should not be it. We should be getting, if we're getting good CO2 readings, then the patient is inhaling okay, and we got a reading that shows us that the oxygen saturation is good. So that's not the issue. The sedation is causing this reading. The patient's in recovery, and yes, they could still be a little bit sleepy, but they're ventilating okay because the end-tidal CO2 is telling us that, and the patient has asthma. Does it look like the patient has asthma? Well, we know pathognomically that if you have a shark fin appearance on your capnography, that is pathognomonic for asthma. And so if you get this shark fin, you have asthma. Second question is a 3-year-old who enters the recovery area on a gurney and shows signs of seesaw breathing with retractions. So what does this tell you? The patient's entering recovery on a gurney, so somebody's taken him from the operating room, and they show signs of seesaw breathing with retractions. So you're having some retractions, that is, it's creating a negative pressure for the influx of oxygen to go into the lungs, and the patient has gasping breaths. Usually gasping breaths mean the patient has difficulty with the amount of oxygen that's occurring. She has had sedation and day surgery suite for multiple teeth extractions. What's the first action that you would take? Select the best answer. Well, there's some reason that the patient's not getting oxygen the way they should. And so you'd want to get the patient in a position where oxygen would be flowing readily to the lungs, that they don't have this seesaw breathing, so you want to make sure that oxygen is applied to the patient and that the patient's position is receptive to getting the oxygen in there. So is it necessary to call EMS? I think the EMS who comes there in less than 6 minutes, once they saw the patient, and they would be very unhappy to see that if you call them over there on a night visit for an emergency and they simply change the position of the patient and the patient starts breathing again, and the gasping breaths go away and the retractions go away. Now, what if you administered albuterol? Is this something that you look? Well, if it happens to be that patient that we saw before with the shark fin capnography going on, then that might be the choice that you want to expect. But if you reposition the patient and the patient starts respiring in a normal fashion and the color goes back to where it was and no longer gasping, you don't need the albuterol. Finally, if you suction the throat, maybe the patient has an obstruction. So when you reposition the patient, perhaps they do have some postoperative secretions that are in there. So sucking the throat would be an answer to do that. But if you reposition the patient and the patient has all his reflexes intact, and the swallow reflex is one of them, they'll swallow any secretions that they have. And if that's done upon repositioning, the patient swallows a little bit, and normal breaths and retractions go away, then that's all you need. You don't need to do another thing. But if you need to administer albuterol, if you see a shark fin and hook up the capnography, then you need to administer a little albuterol. If there's you suction the throat, and that clears up any obstruction, and the patient resumes breathing appropriately, then you've removed the obstruction, the patient's doing well, and make sure they're repositioned so that those secretions that may have accumulated in the throat are being in a position to swallow those and to move forward. What about the third question? Well, the third question says you have a 2-year-old. Well, when you know you have a 2-year-old, the patient does not have a lot of cognitive function, and they present to recovery with the inspiratory stridor. So on inspiration, on the time the patient takes a breath, they have stridor after sedation. And if they've had sedation, let's say they've been intubated. And if they've been intubated with this sedation, the stridor may be a result of some trauma that's occurred to the glottis when the patient was intubated. And if that's the case, what should be done? Well, do you want to call 911? No, you want to do that. So what is one of the things that helps inspiratory stridor? Let's say there was an infection going on and it wasn't noted preoperatively, and the patient came back. As they take a breath in, they have some irritation of the area in the trachea, and it's important to see that there could be some secretions that are in there. And so if you have stridor, usually some inflammation takes place when they have an upper respiratory infection, and typically you hear this on croup. So perhaps the child was doing well and got into the hospital setting, wasn't coughing with noise, but now has stridor, and inspirational stridor is something that is involved with croup or some other irritations in the bronchial tree, and the best treatment for inspirational stridor is administering humidified oxygen. Put that on, and typically when you go to the hospital, when the patient comes out of the operating room, one of the things they like to do is to give them humidified oxygen. And once they have that humidified oxygen, the patient begins to recover quite well. You provide albuterol for the patient. Again, does this patient have asthma? Should be on the history. And asthma is a bronchodilator. Do you need to do that? Well, the patient's breathing okay, so you really don't need to have that. And the final answer is giving dexamethasone. Dexamethasone is a drug that you give for patients who have had some respiratory issues going on, and you do that because it's an anti-inflammatory. And when you give that to the patient, over a period of time, that dexamethasone will decrease the inflammation that the patient has. But if you can answer this by just giving the patient some administered humidified oxygen, you're just going to be okay with that. If that's administering humidified oxygen, if that doesn't work after a period of time, then you might want to again reassess the patient overall. And is it because the patient has an upper respiratory infection? Are we listening to croup noises then? Is that what's happening? And if so, it might be useful to have them continue to administer dehumidified oxygen, or you can have some mist of epinephrine placed on the patient, and this will open up the bronchioles a little bit, but it will also make the patient's mouth feel a little bit better. Giving dexamethasone might be the last thing that you'd want to do, because inflammation is going to have to recover from the application of this drug. Okay, question number 4. You have a 3-year-old patient was sent to recovery after outpatient sedation. Now, who sent them? Where did they come from? Were they coming directly from the operating room after the outpatient sedation to the recovery area? The patient's awake and appears a little bit drowsy. What's sleepy? So what criterion would you select that indicates that the patient is recovering well? Well, there's no indication of anything except the patient is a bit drowsy. Are the eyes open? Is the patient's limbs moving? And are they 2 limbs or are they 4 limbs? Have they been unstimulated with wakefulness for 20 minutes? That's kind of the recovery ideal. If the patient's not been rubbed down or not stimulated with any painful stimuli, and they've been awake for 20 minutes, they just appear to be drowsy, I just kind of monitor them again until they seem to wake up a little bit more. Maybe they're just still a little bit drowsy waking up from recovery. Do they respond to verbal stimulation? We'll say, if it was your child, you say, Johnny, are you okay? Hey, Johnny, it's me, it's Mom, it's Dad. Are you doing okay? And they open their eyes and look at you and they recognize you and they're moving their limbs, and the only thing is drowsiness. Sounds like my child waking up in the morning. So it's not something that's of serious nature. So I would say let's continue to watch until the patient's been awake for 20 minutes and they've been unstimulated. And if they get drowsy on and off, they still have a pulse oximeter on, and you know their oxygen saturation's good, just continue to follow them. And if there's any signs or signals that we should need to step in there and do something further, then we can certainly do that. And number 5 here, the last question. A 6-year-old patient has had multiple teeth restored using opioid medication and hydroxyzine. Okay, opioid medication, we know it affects the carotid and the aortic aspects of whether you need to breathe faster or more. And the medulla and the pons is where you have the hydrogen ion concentration after the carbon dioxide has returned to pass through the blood-brain barrier. And the patient is exhibiting shallow breathing and the color appears pale. Well, the color appearing pale could be from dehydration. But if the patient has had multiple teeth restored and he's using medication, his color, well, you want to be sure he's hydrated, so you want to ensure that, but he's got shallow breathing, so you want to make sure that he's breathing. So what drug would you select to treat this condition? So the person who asked this question has already given you a clue, wants you to think about a drug that's been used. So oxygen should improve the situation that's going on at any time using an opioid medication. But they're trying to tell you something about this, that the patient has shallow breathing. Okay, and epinephrine is a rescue drug for an anaphylactic reaction. I don't think that's the drug that you want to be considering. But it will open up it's a bronchodilator, and it will increase the power of the cardiac contraction. So that's something to keep in mind, but that's not a symptom that was put there. It's the breathing that's the problem. And you can do 4 to 8 puffs of albuterol. If you give 4 to 8 puffs of albuterol, you're thinking about asthma. And asthma hasn't been mentioned here. And asthma could cause some breathing difficulties, but it's usually not of this nature. And it's usually they're gasping for breath is the problem. And that's not mentioned here. They're not gasping for breath. They have shallow breathing. So the only conclusion I can arrive at here is that the patient needs a little bit of support with retrieving their ability to breathe, and it's not involving their full sedation, it's just involving the breathing. So because the patient has shallow breathing, you'd want to maybe start a micro drip of 1 to 5 micrograms per kilogram of naloxone to reverse the sedation effects of the opioid, and that is what drug? It's usually Demerol or some other opioid, could be morphine, but we typically have described meperidine as the drug. And just do a little micro drip, since their IV might still be in place. If not, start one and then put in some naloxone and just titrate and see how the patient is doing. And what we would expect for that is they're going to reverse the agent. Maybe the patient here had some supplemental, maybe they went into deep sedation and they had to have naloxone added to recover the patient, and now they're coming back and you haven't heard that history yet, and you can start this infusion of 1 to 5 micrograms per kilogram of naloxone, and that would be a drug that would help this patient to recover some, and then see what happens. Certainly administering oxygen to have the patient. Oxygen is always good regardless of the situation to help with discoloration or coloration that may be from inadvertent lack of improvement in ventilation. So those are the suggestions that I would make for this patient. So is the documentation of sedation treatment required by state law? And the answer is yes, it definitely is. You need to document, and if you look at the regulations in the Texas State Board of Dental Examiner, you will see that it's required to have a time-oriented sedation record, and it needs to be filled out entirely. You just can't ignore any of the portions of that because it's taken from the American Academy of Pediatric Dentistry, which is a nationally and internationally recognized sedation document for the recovery of patients after sedation, and it helps you to do that. So if you get a hold of that sedation record, you can do another one, but I would recommend that you get the AAPD document because it's fully inclusive of everything you have to do to comply with Texas state law. Is it necessary to be NPO to sedate children? Well, the answer to that is no, but it's preferable. Patients that appear at the emergency room often get sedated by propofol or ketamine to receive some treatments, and even in the hospital if they have to send them to other areas. And if they receive those drugs, what they have shown in some of the studies have shown that the NPO status may allow some consumption, but the risks of aspiration into the lungs is high, and a violation of this rule is not recommended. What I mean by that is make sure you follow the AAPD guidelines. And what they recommend is to have this NPO status, and I'm sure you all know what it is, 6, 4, and 2. And follow that recommendation, and that way you won't have the risk of aspiration. The medical folks don't seem to worry about that, and what they do know is that they've had a lot of successful sedations without the use of the NPO status. People are home and let's say they're out there playing soccer or something happens and suddenly they have to go to the emergency room and the situation is serious and the patient had his dinner before he went to play soccer. In the first 10 minutes he has an accident and needs to go and have some treatment done to his teeth, and you go to the emergency room on call and they say, well, we saw your patient in here, we know it's a dental injury, but to help you out, we gave the patient some ketamine. And is it a problem for doing that? Well, no, it's not. When they have ketamine, it's a dissociative sedation drug, and if the patient has that, you're not going to worry at all that the patient's going to be awake, and it doesn't affect the respiratory and cardiovascular system. You're going to be able to do whatever you need to do to bring this patient, maybe to put a splint on the tooth or whatever is necessary. But the point of this question is, do they have to be NPO? No, they don't have to be, but it's not recommended, and I would never, ever recommend that you violate the rule of NPO status. And number 3 is, can local anesthetics cause inadvertent untoward effects? The answer to this is yes. Local anesthetics are drugs, and they have action centrally that start out as excitement, end up with depression and seizures, and doses must be monitored when used with sedation medications. And when we start thinking about anesthetizing a patient, what we think about is the dose limiting factor is how much local anesthetic that we can give. And it's 4.4 milligrams per kilogram. And if we have a lot of work to do, let's say 4 quadrants need 20 teeth repaired, and you start off and you give a carpal for the first tooth, pretty soon you're going to go over the limitation if you got 4 quadrants to do. And suddenly then you have this patient that starts to get really excited, and then they ends with a little depression. They become suddenly quiet, and then they have a seizure. It's all due to the amount of local anesthetics. And if you've taken this course and read through the other modules, you know that it's possible to cause some damage with local anesthetic. So we need to monitor it, and it's really limited by the dose of local anesthetic we give. Must documents be signed by the dentist? The absolute answer to this is sedation record should be signed by the operating doctor and assistants, initials and name. This is a medical legal document. It's essential. And if you don't sign the record saying that you've counseled the patients about the treatment plan or given postoperative instructions, you're setting yourself up for some claims. If your patients are dissatisfied with what went on, they're going to make a complaint, and the complaint comes to a peer review system, and that peer review goes on, and they look at the sedation record, and there's some scribbling going on there. You don't know who the heck that is. There's no corroborating signature block that comes from all of the staff at that dental office, and so you don't know who signed the document at all. And if you claim that you don't know who this is because you audited this record and you can't tell who this doctor is, and maybe the doctor who signed the record can't even read his own writing, then you're in deep trouble. So you can avoid all of that by clearly signing the medical legal document. Your name needs to go there. Your assistant's name needs to go there. It's recommended that you do that, because if they call some witnesses, you want to know, well, I forgot who the assistant was that day. Well, you're going to be in deep trouble. It's going to be your word against the claims of the patient. So don't get yourself in that spot. Well, that concludes this segment, and I hope that you have taken some of the advice that we've given you, because it's a good idea to recover your patients in a very clear, direct fashion, and that they recover very quickly, go home, and that you learn from your records that sedation dosages can be altered to where you have very light sedation. It's doing the job of allowing your patients to control their behavior, but it also allows the patient that when you are finished, they're going to recover very quickly and go home, and the patient will be satisfied, the parents will be satisfied, and so will you. If you need clarification of any of this information, please send an email to pace@uth.tmc.edu. Here we are in the reference section, and you want to continue to use these references to come up with some of these answers that will help you in your sedation with these patients. This completes this section of the course. It's time for you to take a short exam in order to complete the requirements for streaming video courses. And once you have completed that, the nature of the subject, you need to get a passing score of 80%. It's necessary in order for you to advance to the next section. Upon a successful completion of this exam, you will be visually informed that you have met the requirements to proceed. If you fail to answer enough questions correctly, you'll be instructed to take the exam, and a new set of questions will be provided. You'll have 3 chances to fulfill the requirements,
If you're not successful, you'll be instructed to review this section again. Good luck on the exam. If you're ready to take it, the next section, upon the completion of the exam, you'll be provided a link to continue. If you wish to proceed at a later date, you will need to log in, and no further payment is necessary since this is a continuum.